don't go. Okay? Who has the highest rate?
Man.
Men.
Look again.
What are you men doing?
Enjoying life.
Alright, they are more apt to do, well, I wasn't going to say that. I was going to say life, scary stuff. Alright, and also older people, and why is that? Right? Their center of balance is off, so they fall more, right? Alright. Top reasons for traumatic brain injury to happen besides falls. Roller derby. Yes! How did you know? So we all know that falls is number one. It's your class, not mine. You can be here all day. NBC. Oh. And violence. Oh my gosh, does that not sound the same as something else? Alright. Look at that. I love this picture. It's pretty simplistic. Why do I put this up here? Because if somebody comes in and they have some sort of brain injury and you're not sure what's going on, you can pretty much figure out what might be the problem, right? Or what might be an area. Your brainstem, breathing, digestion, heart rate control. What if they had a brain injury and their heart rate is 20? Not going to really do too much of that, right? Probably not. What if they have motor coordination, equilibrium, balance problems? And keep in mind, this doesn't have to be an injury. This has to be some kind of involvement. So how do we test for this?
Balance.
How many of you have done this? Nobody's going to raise their hand.
What is that?
Right?
Jumping first.
Yes. It's the same thing as what they do for people who are pulled over for DUI. Doesn't have to be the reason, but they do a similar thing there. Occipital lobe for visual, parietal, the sensory area discrimination, some of the way we carry ourselves, I should say. Frontal lobe, personality, behavior, emotional. Also on the upper part, on the other side is Broca's area, which is language production. Language production. Broca's area is language production. Okay? And then in the temporal lobe down here, actually somewhere around here is Wernicke's, right? Your temporal is here. Wernicke's is around here. Your temporal is your hearing, your taste, your smell, your memory, your things like that. Your Wernicke's area is your speech comprehension. The comprehension part. So, for me, if you ask me a question, and I'm like, and I get frustrated because I want to tell you, and I know what I want to tell you. What is that? Broca's. If I'm like, Sammy said 6, 7 snakes were up the skirt, but then it came over to the door and Wernicke's, right? Makes no total sense. All right. Just want you to know the difference between the two.
Sure.
All right. Types of brain injuries. You have mild TBI, right? Concussion. Who has not had a concussion? One person. I like it. And that was a fact. One person. Okay, we've all kind of reason some of them, aren't in those statistics because they don't go to the ED when they should. But we don't think about that because we don't think it's that bad, right? Mild concussion. Okay? It's sudden, it's quick. You could have long-lasting effects from it. Even if I had a mild concussion or a traumatic brain injury, I might suffer from frequent headaches if the light is bright, or if the pressure's high. We have someone who gets a lot of headaches when it rains or when the barometric pressure changes, right? Long lasting. Okay, mild. Memory problems, communicating, concentration, behavioral changes. Moderate. In this can be, actually moderate can be all of these. Problem solving, learning, sensory disruption, because this is all in one area that is contained. Is there any outlet in your brain? It is completely enclosed after the age of 2, right? It's completely enclosed. 80% of what's in there is your brain tissue. 10% is your cerebral spinal fluid, and 10% is blood. So if I hit my head and I start bleeding in my head, depending on where, what could happen?
Intracranial pressure.
Yeah, you're going to have increased cranial pressure and a few other problems. Okay? My brain's not going to explode. It's not going to go outward. Everything's going to happen inward, right? Okay. Severe concussion. This is where you can have loss of consciousness greater than 6 hours. Wake up, they're not waking up, I don't know what's going on. They go through, they don't even know they had a CT. When they wake up, maybe they don't remember they woke up, things like that. One pupil may be larger than the other because it may be that injury is on that side of the brain, right? And just to let you know, some people have one pupil that are larger than the others normally. So you may want to ask family, hey, I'm noticing this. You don't even have to tell them that. Hey, do they have one pupil that's usually larger than the other? Slurred speech, agitation, all these. This diffuse axonal injury is what I told you will not be repaired. So whatever area that happens in will be permanent. So if I have axonal injury in the back of my head, what's going to happen? I won't be able to see or have core injury, right? If I have it on the side, what happens? Might have ringing in my ears, might not have any hearing. It's permanent. It does not grow back. Okay. And of course, if you have head injury, you're always at risk for seizures too. What kind of seizure precautions do we have? Pad the rails. Just 2 of them? Just the front 2? We're going to pad all of them right. Okay. Do we pad 4 rails?
No.
What do you mean no? Do we pad 4 rails? That's a yes, no. Yes, we do. Is that considered restraints?
Yes.
No, because you are doing it for a reason other than the person getting out. You're doing it because if they have a seizure, you don't want them to fall out. It's not that you don't want them to try to get out of bed. Does that make sense?
Opportunity forward. Here comes everybody.
All right. Chronic traumatic encephalopathy. Ooh, this is brain degeneration. You know what this is? This is when you have the football player who's been playing forever and ever, and retired, and then came back and played more, and then retired and played more. I wasn't going to say that. All right. Actually, he doesn't have this, but you can have those people who get those repeated head injuries themselves. It gets worse and worse and worse at a young age. They're actually losing life years, okay? Because they keep getting these head injuries. Guess what? Can't diagnose it till the bed. When they do your autopsy, well, not yours, unless you all play football or some head injury type thing. When they do the autopsy, they will find that type of damage in there. Okay? So all we can do is do what? Treat the symptoms, right? You can treat the symptoms. All right. How's it happen? Falls is number one, right? Weapons, high-risk sports. Not using proper safety equipment, MVCs, pedestrian, military combat, physical abuse. Do you see any educational things that you can tell family and patients? Wear a helmet. Wear a seatbelt.
Get a new job.
Get a new job. We all need a new job. One that pays, what did I say, 200,000? I'm close. No, I'm just kidding. Darn it. All right?
Drive safe.
Yeah, drive safe. Follow the rules. Use your safety equipment the right way. Some people, oh my gosh, my brother-in-law used to work on the Brooklyn Bridge, and he would walk up. That's scary. I'm afraid of heights. He didn't really care. But he would go up to the top of the Brooklyn Bridge, walk, and change the light bulbs and do all that stuff without using his True story.
If you drop, you don't care.
Yeah, high risk sports. Make sure you're wearing your stuff. I'll tell you a funny story about that. This was not my education to my son, I swear. But my son did not do sports at all. We put him in football, trying to get him to do sports. I swear, I have never heard of anyone playing football who never got touched by anybody. The kid never got touched by anybody, and he was defense. Okay?
He was big.
Alright, true story. Then we have to do weapon education, right? Secure your weapons. That's huge. Huge. Okay. Is it a contusion? So bruising. We're talking about bruising of the head. It can happen with blunt trauma, like as in car accidents, penetrating wounds. That coup problem when we have those car accidents. And it manifests itself based on wherever that injury is. And really, like I had said, this prognosis depends on the amount of edema, or the amount of damage in edema, and where is it? Where is it? Okay. I don't really care what the frequent is. That really kind of bothered me a little bit because I saw an order that says arouse and assess frequently. What is that? What is frequently? Does that mean anything to any of you? If you saw that as an order, what are you going to do? What are you talking about? Because frequently to me is something different than somebody else. All right. Care of concussion, though, monitor, immediately report if there's any decrease in concussion. We like them to get better, but if you're seeing it get worse, you're definitely calling somebody. If they have problems speaking, if they have problems with a severe headache. Some people come into my ED and they'll say, I can't take it anymore. I have the worst headache that I have ever had in my life. And that's on another slide, and we'll talk about that. But that happens, and you take that serious, because that is affecting part of the brain, and they're gonna go down very, very quickly, right? that's filling up with brain, or with blood, where else is everything gonna go? Okay. How's it assessed? Comprehension and expressiveness. We're gonna ask them questions, right? Count down from 20 by twos. Remember these 5 words, right? You want to ask them these questions to see if they can comprehend what you're asking them to do, okay? Or if they can, or if you can understand what they're saying to you. All right. Which 2 are broken? You have this one? Good. How many think it's A? Hands up, hands up. How many think it's B? How many think it's C? How many think it's A and C? Here you go. We don't care about the other ones. It's A and C. All right. A and C. Speech is very limited. Short phrases. They can't get it out. Very frustrated trying to talk to you because they want to. They just can't. Broke as aphasia. We already did this, right? You see that a lot on the side of the road, right? Just remember that's not the only reason. That's just a common one. All right. Assessment. We want to know what's drifting. Drifting. Put their hands out like this. Make them close their eyes because you don't want them to see what they may or may not do because they might not feel what they're doing. Drifting, right? Okay? If they're flaccid, we do push-pull and squeezing. We do all this stuff already, right? What if you have somebody who does not respond at all? Ooh, that's when we do that sternal rub, which hurts really bad because you don't have a lot of tissue in between that and your sternum, right? That hurts. I've seen them do the trapezius where they pinch in between the trapezius muscle. That hurts. It hurts. It'll wake somebody up. Supraorbital pressure. I don't see people doing that a lot. That's when they push on their eyes and it hurts. And I don't see them doing that anymore because I can see a lot of tissue damage that they're doing to that. That's more. That's worse than what you're doing over here. Mandibular pressure, they will do extremity stimulation. Have you ever heard? They'll take like a pencil and they'll put it on the nail bed and roll it hard. That hurts. Okay? So if they're not responding to that, they're having, they may be having a very, very severe brain injury that may not get better and may be expected to be worse. And you may be having conversations with family. Okay. Who knows what that is? Yeah. What am I right now?
A 3.
Who said 3? Somebody intubating right now. All right. All right, so your glioblastoma, very, very basic. Everybody knows how to do this. It's pretty much spelled out for you. So now you get to do the work for me. You tell me what that is. Oh, well, I'll hide behind you. This is what it sounds like when nobody's in here. Okay. When they start getting down to 8, what do you think we should be discussing?
Intubation.
Intubation, right? We were already having that conversation with.
HVD.
Huh?
Respiration. The doctor.
Do you want to talk to the family about it?
No.
Yeah, I'm not doing that either. I might go for support, but I'm not saying anything. That is not what I'm doing. So, we say, hey, listen, they were doing this, and now they're down to this. Who are we talking to? We're talking to the physician. So remember roles and responsibilities, right? We are not talking to the family. We can support them. We can have conversations after the physician has talked to them. If they need to have clarification, you do not do that. We'll call the physician back, right? Alright. So, generally we say less than 8 intubate. Really it's less than 8, let's have a conversation if that's what we need to do. Right? Because it's dependent upon the assessment of the patient. That's really what nursing is, right? Dependent on the assessment of the patient. Okay. I'm going to talk quickly about skull fractures. It happens in a lot of TBIs, right? Okay, what's the only movable facial bone? Your mandible. All this you should already know. So we're going to skip it. For time's sake, types of skull fractures. This should all be, you've already got all this, right? Should all be, so we're going to skip that. Just know, one thing we're going to talk about, well, we'll talk about a couple of them, but this is a nice little slide. Okay, skull fracture types. Linear, people can get linear fractures just from falling down and don't even go to the hospital. Okay, so they may have no problems with having a skull fracture like that. If they have a depressed skull fracture, and this will be on depressed, you'll be commuted, either one. What happens is now you see this bone has opened up to what? It's opened up to the brain. And the brain is highly, highly, highly susceptible to any kind of infection. This person, and the one who gets the commuted fracture, with all the little pieces all over the place, is going to go to surgery within 24 hours and have that cleaned out. They have to do something for that. We can't just put a dressing on it, give them antibiotics, whatever. They're going to go to surgery. They're just going to go to surgery. If this is big enough, they may put a plate on there. You've heard of people having plates and things like that, so they may do that. Make sense? Okay. Here's one. This guy didn't get a plate. You might have needed one. You need a plate. And then you have a commuted fracture over there. They'll go to surgery too. Breaks the skin. We already kind of talked about that. Risk for infection. Trying to give you some time back here. Basal skull fractures, one I want to really talk to you about, because I think it's kind of interesting. It's actually one of my favorite fractures too. But you can see that happens, and it happens in the back of the ear. You see the difference here? And on this side, so you can actually see it. That's a CT with contrast. And then you can see that in an MRI, where they actually have the intrusion, and then this is all blood, and it's going to push all this. If this is not taken care of, this blood's going to go somewhere, and it can push all this stuff. And we'll talk about that. All right. What does a basal skull fracture look like? Ooh. These are some telltale signs. You have raccoon eyes. And I guess I could have found a better picture. That one just looks like they went to some kind of makeup place. It just looks like makeup. But they can be pretty swollen and pretty dark. This right here is inside the ear, right? That's the tympanic membrane, and that's blood behind there. And you all see what they call battle signs. That's the bruising behind there. That's where your main injury is, right? This is really important. I want you to understand this. People get this confused. I need you to understand this, right? So what happens is what we can do, it is not a definitive test because we can do it at the bedside. However, it gives us a very, very good idea what's going to happen. Okay? You can take a piece of gauze, and if they have anything coming out of their ear, put it up to their ear, take it out and lay it down. What happens is the red blood cells are heavy, so they will be your middle circle. Does that make sense? The red blood cells are heavy, it's your middle circle. And then what happens is your cerebral spinal fluid will go out and make either a yellow or a tannish halo sign around it. So this is red. This is kind of a bad picture. This could be lighter. It could be like a light tan color. You can definitely tell the difference. But that is what you call your halo sign. And it is indicative of cerebral spinal fluid. And that's not a good sign to have. So your physician will need to know that. You probably already know because they're probably going to do it. Although if you do see that, it's not invasive. You can go ahead and do it and then let them know. Make sense? Any questions? Any questions I can answer? Don't ask me questions I can answer. Okay. This is just how they diagnose skull fractures. We kind of already went through this. X-ray will show your bone, right? I don't have one of those. Here's a CT. This is with contrast. The reason I know it's with contrast is because this is all dark. If it's all shaded, it took up all of the contrast, right? And you can see the broken bone there. Okay? MRI, you'll get a more accurate picture. It's extremely detailed. And they can piece it very narrowly or very far apart. They can control how far apart their pieces are that they're doing. And then they can do a cerebral angiography to make sure that there's maybe not a blockage, or if there's a bigger bleed and where that bleed is, right? Just like they do for hurts. Here's the different kinds of hemorrhages that we have. Okay? Usually, like your subdural hematomas, you see this gray? That's within inside the brain. So if you have like a subdural hematoma or an intracerebral hematoma, usually those can be pulled into the tissue, so it doesn't have to make room. And you can have chronic ones, and we find them a lot in people who drink. We find them in alcoholics a lot. So sometimes, it used to be, we would take alcoholics and we would put them in the hallway, not realizing that, you know, sometimes they had these chronic problems until we started doing CTs on them and finding them. Okay? I'm not saying that's the only patient population, but we do find them in there. Okay? Your epidural hematomas, do you see how it's on the other side of the gray? Those in your arachnoid hematomas, which is not on there, will need immediate attention. They will have to go to surgery. Okay? They will either have to have clot taken out, or they will have to have the accumulating blood taken out. Because the arachnoid, that's a spider. Arachnoid hemorrhage is arterial. point out, the first one has to have surgery and respiratory support until the patient is stabilized. Okay, and then the other one, this is the one I told you, subarachnoid hematoma is the one where people will come in and they'll say, I am having the worst headache of my life. Well, of course you are. You're bleeding in your head and everything is moving around. Of course you have a headache. You probably have high blood pressure along with it. Okay, you're going to surgery. Make sense? Alright. What causes them? Oh my God, falls. Falls is everything. Falls actually for most things is #1 nationwide. Okay, MVCs and trauma are #2 and 3. So it's consistent across the country. Aneurysms can happen. It can be something that you're born with, like the arteriovenous malformations, bleeding disorders. Can't help that. Some medications, if you are on blood thinners, you're taking a chance. Sometimes if they come in and they're having a stroke and we give them blood thinners to clot bust, we can cause that too. Okay? And liver disease and alcoholics, which we talked about for the hematomas. And here's just a slide I put together or found, showing you different kinds of pupillary assessments that you might see. And some of them, like the second one where they're really big like that, you can see on people who take a lot of barbiturates, right? I'm not saying that all of them that are big like that, they're all taking barbiturates. But you can ask them, it's a good question to ask, are you taking these medications? Do you take barbiturates to help you sleep? That would be a nice way to ask. Things like that. Or if you see them pinpoint down here, what could they be on? Be an opiates, right? Nice thing to ask. Are you taking pain medication for anything that's wrong with you? You don't want to say you become very wrong. You don't want to say stuff like that. But that might be a reason. It can also be reasons for having some sort of brain injury. Okay. So, intracranial pressure. So if I have some intracranial pressure, it's going to cause me to have blurred vision, probably a headache. You might see double because it's affecting the back of your head or the front of your head. Pupillary changes. It might make me vomit. That's fun. And I can, in physician, not the nurse, can do an assessment called Doll's eyes. Does anyone know what that is? Yes, no, maybe? All right. If I'm laying down and they jerk my head this way and this way, which way are my eyes going to go? They're going to go they'll go the way they do then. But if I have doll's eyes, which will show that I have some kind of brain problem, they will stay forward. They stay forward. But yeah, if you move your head, I'm going to go usually wherever they tell me to.
And that would be indicative of the pressure?
That will be indicative of some kind of brain lesion, brain injury. Yes. Hey, we all know decorticate and cerebit, correct? Is this something that we're like, oh, we'll get you up tomorrow and walk around the hallway, do jumping jacks? Is that what we're going to do? Probably not. If we come down to where they're decorticate and then turn to cerebit, that is indicative that you have a patient whose brain is probably herniated. Come back from that. Okay? We're having a conversation. Well, we're not. Who's having a conversation with the family? Jesus. Somebody say Jesus? Don't put that on the test. If it's a female, fill in and I say Jesus, no.
That's a point. Jesus is
Physician
never
will
gonna
probably
be
grab, I can't get over Jesus. Grab chaplain, which is close to Jesus, right? And they'll sit down with the family and have a conversation about what they would like to do, who they would like to call to come to the bedside, blah, 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 blah. Make sense? No Jesus. And if you do get Jesus, I want to meet him. I'll give you my phone number. Y'all have my phone number. All right. What interventions are we going to do for them? Maintain their airway. Basically, we're going to take care of them as best we can and keep them in as, they're not really functional, but we're going to keep them in as good, pristine condition as we can. Especially if we're expecting the family to come say whatever they need to say to the patient. Make sense? So we're going to still be turning them, making sure their skin is good. We're going to still make sure that they are breathing well. I gotta see what I'm, make sure we're watching their vital signs, make sure they're not becoming hypotensive, and we have to give them medication to just keep their blood pressure up. We're gonna put them on seizure precautions. Suction only as needed. What if I had an order that said, I need you to suction this patient every 2 hours?
Call and be like, why?
Why am I calling? Is that wrong?
Yes. Yes.
Why is it wrong?
Too much manipulation.
It is wrong because you want to minimize how much intracranial pressure you're putting on this patient. So while we're taking care of the patient, maintain them as best we can for whoever we can, you know, making sure that we don't increase intracranial pressure is part of that. So we're not going to be suctioning them all the time. We can't do that. Only if they need it. I mean, that would be like me. Would you suction me right now? I don't need to be suctioned. So, only if needed. Alright. Okay, this one is interesting too. So, medical emergency management hematomas, and I've talked about this through, what they'll do is they can do an EEG where they put all the white things all over the head and they watch the measurement, and then it sticks in your head and you can't ever get it out. They'll put them on anti-seizure medication we talked about. They could do some burr holes and some craniotomies, which are some really cool pictures that I stuck up here. That's really cool. And they'll give mannitol. Why do they give mannitol? What else can they give? They will give formosus. What else can they give them? They can give mannitol, they can give 3% normal saline or 7%. They're going to give a hypertonic solution, is what they're going to give, right? Generally, it is mannitol. And then they'll follow it by Lasix, and they'll go ahead and get rid of some of this extra fluid. Okay? Now, one of the things that they'll give, I highlighted, is a calcium channel blocker called nimodipine. And it is specific for cranial patients because it has a smooth muscle relaxant component to it, as well as dropping the pressure. So that's the medication that they will use. Make sense? In some cases, they may use therapeutic anticoagulation, but they use it very, very sparingly, because most of the time they're going to, these patients are in surgery and they're already bleeding, so they don't want them to bleed out, right? So they're very, very, very careful about how they give that. All right. And any sudden change in client's behavior certainly is an indication of increased cerebral pressure. Okay, any kind of behavioral change, if you're talking to them one time and the next time they're out of bed confused and they can't find McDonald's, that's a problem. Okay, I already told you this a long time ago, right? 10% CFS, 10% blood, the rest of it is all brain tissue, right? It's a fixed compartment. I lied, I said 2 years, I lied by 6 months. Okay? It's not even on the test because it's not a kid test. Yay. Not my favorite patient population. Okay. Okay. And this is pretty much the same thing because it's a fixed compartment. Anything that happens, bleeding and everything, is going to force pressure down, right? And then start the herniation process. All right. Trying to see if there's anything in here that I have to worry about. Pressure onto cranial vessels and will decrease. I don't have to worry about that. That's not. I should have taken that one out. All right. Think of all the systems of the body related to nursing diagnosis. How would you care for them? You have this patient, you come in, and they can make noise. They can't really move very well. How would you like to take care of them? You can even ask me questions. I will answer you. No, I want you to tell me how you're going to care for a patient who cannot move very well, is pretty much bedbound, can talk a little bit. You can ask me questions. I'll start. I.e., can the patient swallow and eat? No, he has a peg tube, so what are you going to do?
Peg tube, yeah.
Right? So you're going to feed him through his peg tube. His medications are going through the peg tube, and you're going to watch the skin to make sure that it doesn't break down. That's what I'm looking for. Okay? Good question.
Is he intubated?
No, not intubated. What kind of assessment are you going to do? He's not intubated.
Or swallowing?
Who does the swallowing test? Speech therapy. So you can do that. You can get speech therapy, you can do a swallow test, so you have one of the books, that's good. What are you going to do respiratory wise? If he needs it. She said if he needs it. Think basic. Respiratory assessment, right? Is it effective? What's his O2 stats? Good. No.
What is the blood pressure?
Probably a 10. Does not need to be restrained. Not trying to get out of bed. What else would you do? Skin assessment. We're turning them over too, right? Okay, because looking at the skin like this is not a full skin assessment. We have to turn them over and look at them too. I've seen people do skin assessment. Oh, I'm all done. Bowel assessment. And that's really, really important too. How are you going to find out when the last time you had bowel movement was? Yeah, they already left. They can't talk. Exactly. Or go look through the when it was. Nobody told me when. The last time was 7 days. I don't know what to do with this person. Talk to your team, right? That's a great question because you're asking your team. All right, we'll move on. It didn't have to be all 16 systems. All right. Ooh. You guys need a break?
No.
Do you want to wait for the baby for a little later? Yes or no?
Yes, yes.
Okay. Just get it over with. Okay, I got it. Okay, potential complications for brainstem herniation. What do you think? Pressure ulcer formation. They're going to get pneumonia because they're not going to be able to breathe very well. It's going to be affected. Your brain is the one who helps you breathe. If you have herniation, that's not going to happen very well, right? So you may run into pneumonia. DVT formation, contracture, altered nutrition. It's your brain controls everything along with your heart and your nervous system. So if they're not working well, your respiratory system, so if they're not working well together, you are going to have all these problems, right? All right. Management. They will be laying down, right? If they are now not responsive, that they are alive, they are breathing, you keep their head and neck at neutral position. So we are rolling them side to side, right? We are keeping them that way. What if they get tired? I guess you wouldn't know if they got tired. Another thing we can do, I'm thinking of somebody who might be awake and might be like a quadriplegic who would like to eat. They actually can take the bed and put it in Trendelenburg too, right? They're still flat. Does that make sense? Assess for hydration. How do we do that? Skin turner. Look at their mouth. Blood pressure, heart rate. Output, I know. Alright. Surgical management. Do not have to know this. This is ICU nursing. I just wanted to put this up here to let you know. There are other kinds of interventions that the surgeon may do. They may put in devices that will take blood out of the center. I mean, it goes all the way down, right? And as an ED nurse, I'm going to tell you that if we're going to do something like this, you come down and take care of this patient because it is not my forte. I do not mess with this stuff, and neuro ICU does, and they will come down and take care of the patient. So, but I know that they have these that go all the way in to take care of blood. They will do clot, to take out clots. They will monitor intracranial pressure with catheters, and sometimes they can put bolts in to maybe stabilize their cervical area. Okay?
And I'm sorry, that needle doesn't damage the brain, it just goes inside the brain?
Well, if you think about it, sometimes you have to go, which one is going to be worse? Is it going to be in your neurologist so they kind of know their pathways? If you think about it that way too, it's not just like, take this and shove it in your brain. They know their pathways, they know how to do things, and if they have to do it, it's not an easy decision to do. It's, I have to do this in order to prevent this. Yeah, that's a great question though. All right. So they'll still management of intracranial pressure. We want to prevent any secondary injuries. They are high risk for falling, and they do sometimes get out of bed if they are able to, and we don't know it. So sometimes, unfortunately, we do have to restrain them. That's not a fun thing to do. That is a last resort, right? We can elevate the head of the bed, definitely stool softeners, eyes, nose, all that stuff we've talked about. I think you've gotten most of the stuff. Pupils for equality, shape, reactive to light. We did not talk about blood sugar levels. Is that important when you're talking about brain injuries? Yes. It is, isn't it? It's very, very important. You can even do that when you do your halo test, correct? Right? Take some of that fluid, test it for sugar. Is that a positive test?
Yes.
For an injury? Absolutely. Okay? Monitor temperature, maintain normal thermia. Sometimes they can't do that when they have a brain injury, right? Because your brain is the one that is making you warm and making you cold and making you, and they may not be able to do that. So we may be having to do what? Get bear huggers or get them cold. Whatever's going on with them once we assess them. Cushing's triad is, again, another step towards an open room. So you have a widening pulse pressure. Your systolic is a little higher than your diastolic, your bradycardic, irregular respiration patterns. It's going to be not so far from this, and you're going to be making family phone calls to let them know that they may want to come in. And the physician, or what you can do is you can call the physician and say, this is what's happening. Could you please call and talk to the family? Or the family is here, could you please call or come ASAP and talk to the family? Remember, that is not something we are expected to do. Okay? Because they're going to have questions, and it's not going to look good when you go, why is this happening? I had no idea. Anyway, so the physician is the one who should be doing that. Brain herniation can herniate in several areas, mostly downward. Because really, that's almost the only place it can go, right? Okay. So, early signs, of course, is the changes in the eyes. That's why it's really important to make sure that you're doing a very thorough neuro assessment in your cranial nerves, right? Your later signs is level of consciousness. Usually that is one of the earlier signs that we notice is level of consciousness. And then, of course, your respiratory, and you kind of know it's impending. You know it's impending. You're getting the room clean for visitors, that type of thing. And then very late signs, they are dilated and fixed. Meaning you use your little pin like they're not going to do anything, and it's just a matter of time, and your family is going to be at the bedside, and we're going to care for who? The family. Please care for the family. Give them what they need. Offer them a drink. Offer them something. Be very, very cognizant of that family. They are watching everything you do as well. Okay? They want to see how you're taking care of their loved one and things like that. So be very cognizant of that. I like that picture. That's a very, very swollen brain. And I thought it was a good picture, and here it is. Alright, we already talked about mannitol. They will give the osmotic diuretics along with that. Mannitol, you don't even need to know this, is given via filtered tubing. And then they'll go ahead and give, they'll monitor eyes and nose, and then they'll give the Lasix furosemide. Okay, that will help decrease the edema, the sodium uptake problem, the CFS production. They will also give the corticosteroids to decrease the edema, increase swelling, and remember, they will give a calcium channel blocker. What is that? And what is this going to do? It's going to help lower blood pressure and heart rate. anticonvulsive and anti-ulcer. We want to make sure that they do not have seizures that we talked about, and we definitely want to protect the stomach, right? Because we're going to be in a position where that patient could be in metabolic acidosis and have all that acid in there, so we may be giving meds like that. Very good. See how we just kind of throw that right in there. All right. For ventilated patients, we're going to give them morphine or fentanyl. Is a ventilated patient, do they have pain? They're not awake, but they could have pain. Absolutely. They could have pain, so we do give them that. And they will be on Versed, Diprovan. Some will be on Ativan, especially your brain injury patients. They will not be on Versed and Diprovan. They will be on one or the other. Diprovan is the one that looks like milk. Okay. All right. So what we're going to do is we're going to maintain the airway. We're going to make sure that that tube is right where it says it is. So a lot of times when they intubate, they will say it is 24 at the lip, right? And then we're watching skin. We're making sure that we give good mouth care. Are we suctioning every hour? Only as needed. Now what happens if you go in and this is at 24, or they said it was at 24, and now it's at 22. What are you going to do? Call the doctor. You can assess, that's good, because you're going to have time to do that because he's not going to call, right? You ask somebody to call the physician and then they will have to fix it. If they are actually having some respiratory difficulty because it is messing here, take it out and back. Call RT. RT can read. Okay? Oh, we went backwards. Sorry about that. Also, when somebody comes back and they have head injuries, they are very sensitive to light and they're sensitive to dark. So when you bring them back from whatever procedure they went to, have some light for them so they don't get so confused as to where they are. And that actually goes for anybody, whether they've had a head injury or not, but especially for them. And then you may have to induce or create their sleep-wake schedules for them because they may not be able to do that. So you may be being the fake sun and moon, if you will. Skin infection. And we think of some of the other things that they may have dressing in casts. They may have other things wrong with them, just a head injury. We talk about just head injuries. We talk about spine injuries, but we know that there's other injuries that go along with it that we need to be watching, correct? Yep. And mittens to prevent self-injury. The state does not recognize them as restraints. Okay? Just to let you know, if they can move their fingers, I'm telling you the truth. Don't be looking at me like that. I'm telling you the truth. If they can move their fingers inside those mittens, they are not a restraint as of 2020.
And they don't need a doctor order?
Yes, you need a doctor's order for restraints.
But for instance, is there a doctor order for that?
No. You don't necessarily, I personally would to let them know I'm putting them on them, even though they're not restraints. But technically, no, you do not, because it's not a restraint.
But for aplex purposes, are they?
For what?
Aplex purposes, are they?
No. This is a national organization. This is a national organization that says that if you can move your fingers in there, it is not a restraint, because restraints are for joints. Restraints are for joints. So if I have my hands like this, I can't bend my elbows, right? If I have my legs restrained, I can't bend my legs. You see what I'm saying? But I can move I might not be able to feed myself, but there are some people who don't have gloves who can't feed themselves. But if you can move your joints in there, it's not a restraint. True story. All right. Here's your seizure precaution things. And I just wanted you to notice this one right here. This picture's weird. This is down because they're worried about you thinking that this is a restraint. But if this
You
is
see, they
up
didn't
and
put
it
all
has
for
a
sale.
it has a pad
And they
on
didn't-
it,
and
it
they
will
didn't
not
put
be
up all
considered a
four, they only
restraint
put up three.
because that's not the purpose of it.
But she said when it's
You
see-through, so
understand?
put up all.
That's not the purpose of it. Because to me, if this person had a seizure, they're gonna fall out this side of the bed. Does that make sense? And it's gonna be bed in low position. Why are they sidelined? Why would you prefer your patient to be sidelined?
If they're vomiting,
Yeah. Good. Okay. Okay, this is pretty much the same thing. Evacuation of blood clots. These patients, we hope, get better because we fixed the problem. They went to surgery, they had the clot removed, they have the dressing on. And so we are going to be looking for improvements and assessments as they go on, right? So we're going to continually, whatever your floor has outlined, watch their vital signs and neuro checks very closely, cardiac monitoring, strict INO, range of motion, all those things that we've talked about. Rehab starts when? Oh, yeah, when they first come in, right? Rehab's really good too, and psychosocial, and get spiritual involved. Spiritual is not just to come to the bed and say, you know, whatever. They really work with families, they really work to talk to patients. They're very comforting. They're a lot more than what people use them for, which is a shame. I've known many of the chaplains, and they do a lot more than what you think they do. But they can help rehab all three of those with personality changes, noticing if they come, anxiety, coping, guilt, work placement problems, financial problems, burden to the family. They will come. I know spiritual will come and they will talk to the family about how they can help or what their needs are and give them references and things like that. So they're very, very helpful. So please think again of your team that's going to help you take care of this patient. And then persistent vegetative state, right? They're probably not going to get better, right? They're like this for years and years and 10 years. And who remembers the big one when I moved down here? That was a long time ago. Which is Terry Shiver days. Right? Okay. It is very emotional. It's not just about the patient sometimes. You have family squabbles over it. It becomes ethical. It can become, court. So be careful how you phrase what you document always. Okay? Okay, state of coma, patient is awake, no cognitive awareness. You can't move, they're not moving. And what happens is the physician will go in and they will determine whether that patient is brain dead. And what they do is they will go in separately. They do not go in together. It's not like, hey, let's go see if this person's brain dead together. They don't do that. I go in, I do my assessment on the patient, which will include an EEG on the patient for brainwave activity, do my full neuro assessment. I will write mine up, and then a neurologist who is not talk to me will go in and do the same thing. You have two people who said the patient is brain dead, the patient's brain dead. Our next conversation that we're gonna have is going to be extubation and what we're gonna do. So who's gonna talk to the family? Yeah, I'm not. I definitely am not. That is correct. So the MD is gonna have a conversation with the family. They're gonna get a plan together. Sometimes that does involve you. They may like people to be around when that happens, and that's okay. It's okay to cry, it's okay to be emotional, it's okay. But that does happen. And then we do have organ donation as a consideration. Who brings up organ donation? The organ donation people do. So what happens is, way back when the patient first got intubated or became not so good, not so stable, somebody called them, and they have followed that patient all the way to now. So they know. And then they will come and they will talk to the patient. Make sense? Okay. They will, well, they can't talk to the patient. Your brain dead? Did I say patient?
Yes.
The family is now your patient. I meant the family. Yes, they will come and they will talk to the family. All right, prevention. This is your education you are telling everybody, because you don't want anyone to be on that last slide, do you? And this is stuff we talked about. Buckle up, wear your helmet, lock your gun up. Don't own a gun. Some people should not own them, right? That's my opinion. I'm sorry, that's my opinion. Anyway, if you're gonna own them, be responsible. Keep your health. Go see your physicians. Go see all your physicians that are your expert physicians, your neurologists, your urologists. Keep those, right? Watch your kids. Any questions in the whole wide world? What? Shh. I have a question. I can't hear her.
If you have a patient with a brain injury, you have to reposition every 2 hours. Do you need 3 people for that too?
Good question. So she's asking if you have someone with a brain injury, correct? Someone with a brain injury, and you need to turn them every 2 hours. They will probably be on a specialty bed, to be honest with you. If they're not, then you're going to position them the best you can with the 3 people turning. Because remember, they're not a spinal cord, they're brain injury. And that will be dependent upon whatever the physician writes.
Okay, what about if they have a spinal cord injury?
Spinal cord injury, they will have to be on spinal precautions. So it will be what the physician writes. Because it's really hard to turn a spinal cord injury and support their head unless they have something from physical therapy that supports their head when they turn, which I think they do. But your main, it depends on where their spinal cord injury is. If I have a higher spinal cord injury, I probably can turn them, put their head on a pillow. You see what I'm saying? And they're still aligned. The brain injury patients, you'd still do the same thing.
It doesn't matter. It's only if the spine
a higher spine, I would defer to whatever the physician would order, because that would be very different. Because they may have special pieces of equipment they're using or something like that. So for that, that's who I would defer to. Absolutely. That was a really good question. Nobody ever asked me that before. Anything else? Okay, I have a question for you. The seats, 315, okay. Anybody want to go home? Yes. 3 people want to go home.
Yes.
That was awesome. Oh, you know what? I forgot. I apologize. I'm not kidding. This is only 8 slides. I forgot the Parkinson's.
I was like, damn.
I'm sorry, I saw the brain, it said the end, it was the end.
Right.
I promise. This will take 5 minutes. They don't know why Parkinson's happens. They only have medication to control symptoms. They do not have a cure for it. Okay? Why? Here's the symptoms. Tremors, muscle rigidity, bradykinesia, postural instability. It starts with tremors, usually in the hands, until they're like this and they get slower, And the way that they diagnose it is to rule out other stuff. Okay? They think it could be environmental or genetic, exposure to chemicals in older people, more common in males. Sorry, men. H&P, they're going to ask, when did your symptoms start? Resting tremors, rigidity assessment. You're going to look for that rigidity, that assessment piece for Parkinson's. They will look for hypomimia. Your muscles don't move as well, so this is my happy face, this is my sad face, this is my excited. You see what I'm saying? There's not a lot of change in face. Trying to go slice emotional changes, bowel bladder changes. At the end, they will probably become incontinent and have those kinds of problems, and significant fatigue. This right here is the one I started to tell you about. It takes about 15 minutes, but it's really, really cool. How many people know who Michael J. Fox is? This is a nice little interview that he did regarding Parkinson's disease. It's very interesting. Watch it. And then this is just the face, the hypomimia. Diagnostic, there is no test for it, we don't know. They will do labs, imaging, CSF, if ordered, CT, MRI. And if it's all negative and they don't know, they're going to start them on levodopa or some kind of medication, because the reason they're having this is because their dopamine levels are in the toilet, right? Can't test for that unless they're... So if they give them levodopa or some kind of combo drug and they respond to it, they probably have Parkinson's. So here's meds. Levodopa, carbidopa. It's just the different kinds of medications that will replace that dopamine and hopefully improve their symptoms. Nursing care, range of motion. It is not very different than nursing care we do for any other medication. Skin care, assistive devices. We give them probably a wheelchair or a walker. Foods, easy to swallow, high calories, right? They're not moving very well. We want to make sure they keep their protein up in their muscles, right? Surgical intervention. These are only to control symptoms, right? They'll do maybe a deep brain stimulation, a phlebotomy, thalamotomy. Right now, I put this one on here. They are now, it's new, it's ongoing research using fetal neurotissue in hopes of significantly improving Parkinson's, which I thought was really interesting. And then here's your care team. Physiotherapy, speech and language, occupational, home health, right? They're going to look at your house, make sure that you can get around, there's no rugs all over the floor and things like that. Self-management education with physical therapy, healthcare resources, they can get to where they're going, they have support. And this is the whole evaluation of all the patients we discussed today. It was approved many